Good morning, everybody, and welcome to today's Share and Learn, the Office of Oral Health's data updates and tools in support of oral health promotion. I'm Janelle, a part of the co-TAC team here at UCSF, and thank you so much for joining us this morning. On our next slide, we're just going to review the disclaimers, acknowledgements. We're funded by the Office of Oral Health, and here you can see our disclaimers. And then just a bit of housekeeping before we begin. Today's meeting is being recorded and it will be posted on the COTAC website and YouTube channel. You'll receive a follow-up email with recordings, slides, and resource links. Feel free to post questions and in the discussion and chat box, and we'll have dedicated Q&A time after each speaker. If you experience any technical issues, Xenia is available to chat and assist. Excuse me. And finally, as always, we value your feedback, so please take a moment at the end of today's session to complete our evaluation survey. Xenia will drop that link in the chat later on at the end. Alrighty, so we can get started. So today's objectives are on the left and the agenda's on the right. Today's presentations highlight oral health data trends, maternal and child oral health, and new tools you can use in your programs. Before passing it to our first speaker, let me offer brief introductions of today's presenters. Dr. Pendurkar is the State Dental Director of California, overseeing the Office of Oral Health at the California Department of Public Health, bringing over 2 decades of leadership experience in public health dentistry and community-based care. She is dedicated to advancing oral health equity statewide and has served in key roles across county health departments, community health centers, and national public health organizations. Shamila Hashmi is a research scientist in the Office of Oral Health Surveillance and Evaluation Unit, where she supports statewide surveillance activities and uses data to monitor and improve oral health outcomes across California. With clinical training in obstetrics and gynecology, an MPH, and a Cal EIS fellowship, she brings strong applied epidemiologic expertise and a commitment to advancing equitable access to oral health care. Margaret Trimble is an oral health epidemiologist with the Office of Oral Health, bringing 20 years of clinical dental hygiene experience and an MPH from UC Berkeley to her role. She applies her clinical background and research training to examine oral health inequities and support evidence-based improvements to oral health care across California. Xenia will drop a link to our extended speaker bios in the chat. And now I'd like to welcome Dr. Pendurkar to share updates from the State Dental Director.
Good morning, and thank you. Thank you for that introduction. Good morning, everyone. Can everyone hear me okay?
Yes.
Okay, thank you. Thanks again. Thank you all for being here. This has certainly been an extraordinary year, and I would like to start off by saying that we greatly appreciate your ongoing dedication to good oral health for all Californians. We can continue our efforts to positively impact our local communities through our ongoing collaboration and innovative solutions, especially with data to highlight your efforts, which is the focus of today's Share and Learn. We also want to inform you, just as an update, that the DRMS has been a difficult endeavor and is currently on hold. And the other update I'd like to share is that we are currently working with your leaders to develop the next local oral health program grant cycle, and that we hope to share more information with you all soon. Next slide, please. Next slide. So next, I'd like to share some of your success stories from local oral health programs, showing the impactful work that is being done statewide. These stories show how local oral health programs are saving smiles and lives through early detection, care coordination, and innovation. And these highlights that you see on the slide are from Northern California and the Bay Area. I'll pause here for a second for you guys to read this. These are just a few. This list is not exhaustive by any means, but we just wanted to capture a few of the local programs and highlight some of the work that's ongoing. Next slide, please. And so this slide here, you can see the success stories from some of the programs in the Central Valley, as well as in Southern California. And again, thank you for everything that you've done, and that you continuing to do to address the challenges and make a difference in your community. This is hard work. This work is reflective of everything that you all are doing, and we greatly, greatly appreciate that. Next slide, please. So in our California Oral Health Plan, Goal 4 focuses on communication, which is informing and educating interested parties about oral health programs and policies. And we've been doing exactly that at local and national events. Some of them are listed here on this slide, and I'd like to share some of these efforts with you. So in the past 6 months or so, we've been actively engaged with presentations at local and national events. You can see them listed. I found that many dental providers are unfamiliar with the local oral health programs available in their communities, or may not know how to engage with them. And to help address this, I make it a point to share practical suggestions and provide links to local resources that can help guide them in getting involved and get connected with their local oral health programs in their own counties. Next slide. As for our social media presence, this is a sample of the state level outreach we've been doing to build awareness around community water fluoridation. If you're not already following the California Department of Public Health, I encourage you to do so and to share our posts across your networks to amplify our collective impact. Increasing collaboration and sharing information will help strengthen local efforts, boost public engagement, and advance health equity in our communities, as well as achieve the goals and objectives of the California Oral Health Plan. Next slide, please. Related to our continuing efforts to support community water fluoridation, on June 11th of this year, the Office of Oral Health convened the California Fluoride Strategic Meeting, along with the UCSF fluoridation consultants and the California Dental Association. This event brought together respected professionals from across California and the nation, representing fields in health sciences, healthcare leadership, environmental sciences, and the State Water Resources Control Board. The purpose of this meeting was to establish a clear framework for developing the next comprehensive California fluoride plan. The plan will guide efforts in an evolving landscape to promote fluoridation through effective communication, education, and by demonstrating its cost effectiveness. Participants emphasize the need for renewed advocacy, refreshed messaging, and stronger strategic partnerships to maintain and strengthen fluoridation efforts across the state. Next slide. So as you know, community water fluoridation is not just a public health intervention. It's actually a cost-saving investment. An Office of Oral Health has developed a county-specific estimate of this cost-saving analysis as part of the communication asset of the California Fluoride Plan. Return on investment infographics can help local health jurisdictions and public water system organizations visually demonstrate the economic feasibility of initiating or maintaining fluoridation. And some of the numbers are listed on the slide, but Margaret is going to go into details with her presentation on this ROI infographic. Just to give you an example, residents of communities with fluoridated water spend less on dental treatment, saving an average of about $44 per person per year. And as an example, if these residents spend these savings on taxable purchases instead of non-taxable dental treatments, there's potential annual sales tax revenue for local use about $800,000. So on average, communities with fluoridated water experience a 25% reduction in cavities. And this outcome not only enhances individual oral health, but also has broader implications, such as reducing the number of missed school and work days. So if you'd like to have something similar developed for your county, please contact the Office of Oral Health and we'd be happy to develop one for you. Next slide, please. One of the data topics in today's Share and Learn will be a review of the latest Maternal and Infant Health Assessment, or the MIHA survey data, which shows consistent improvement in dental care usage during pregnancy. This data was shared with you a few months ago, and the increase, as you can see, is across all 9 MIHA regions statewide. The surveillance team will share. Today, Shamila is going to be talking about the regions map in the MIHA portion of the Share and Learn. And the California Oral Health Plan identifies priorities, goals, and objectives to address the burden of disease and to increase access to oral health services for all Californians, specifically for high-risk population. The plan identifies pregnant people as a high-risk population. So an increase in dental care usage is a positive step towards better health and equity. Next slide, please. Also on the topic of community water fluoridation, as you may know, on October 31st of this year, the FDA published a notice restricting the sale of unapproved fluoride drug products, which is prescription fluoride supplements, labeled for use in children under 3 or older children at low or moderate risk for tooth decay. And so on the same day, the American Association of Pediatric Dentists and the American Dental Association reaffirmed their support for the evidence-based use of daily fluoride supplementation prescribed when indicated for children at high risk of dental caries and without access to optimally fluoridated community water to strengthen the teeth and prevent cavities. On November this year, November 10th of this year, CDA, California Dental Association, published an article also reaffirming the support for the appropriate use of fluoride supplements as an effective strategy to prevent dental caries, particularly in communities without access to fluoridated water and among children at high risk for tooth decay. The Office of Oral Health remains committed to evidence-based public health practices and is currently reviewing the FDA's notice and its implications for oral health and equity in California. Next slide, please. And so let me say again, here at the Office of Oral Health, we know that you're doing your best every day to improve the oral health of your communities, and we greatly appreciate your partnership. Please continue to share your ideas and successes with us. Every step forward matters. Thank you again for your hard work, and that I hope that you find today's Share and Learn informative and useful. We hope and plan that we can have more Share and Learns that are focused on data. We heard you. We heard that this was a need from most of the LOHPs trying to understand what happens with the information that you send us, as well as some of the data that we sent you through emails, and maybe there's no capacity on your end to kind of understand and digest that data. And so we are hoping that in the next year, we will have more of these type of Share and Learns where we can talk about data and explain some of the information that's being shared through emails and newsletters. So with that, I will pass it back to Janelle, and we'll take questions at the end. Thanks again for your time today, and thanks for being here.
Thank you so much, Dr. Pendurkar. I apologize. I'm going to keep my video off. My internet is buggy, so I'm hoping that this will help. But thank you again. That was really great to see all the counties and the highlights of what each county's been doing throughout the state. So our next speaker, Shamila, who will share statewide data and insights on dental care during pregnancy in California. We'll turn it over to you, Shamila, for that presentation.
Thank you so much, Janelle. Hello, everybody. A very good morning. Thank you so much for taking the time to join the session today. My name is Shamila Hashmi, and I'm a member of the Office of Oral Health Surveillance and Evaluation team. So today, next slide, please. So, thank you. So as you can see, the learning objectives here that have already been shared. Today, I will be sharing key findings from the Maternal and Infant Health Assessment, or the MIHA survey, regarding utilization of dental care during pregnancy in California. And we'll together see how these patterns towards improving oral health care during pregnancy can influence our continued work towards achieving equitable oral health during pregnancy. Next slide, please. So, pregnancy is an important time in an individual's life because of some physiological changes that happen during this time, and also maybe some behavioral changes. There is increased susceptibility of a pregnant individual to develop certain oral diseases, more commonly periodontal disease and dental caries. As many of you are already aware, periodontal disease is a disease of the gums, and if it goes untreated, it may affect the underlying supporting tissue of the tooth and may result in long-term tooth loss. So, professional dental care is really important during pregnancy because it's a time where early diagnosis and treatment can prevent the exacerbation of this periodontal disease. Poor oral health in expectant mothers is not only detrimental for the maternal health, but it may also lead to adverse pregnancy outcomes because the chronic infection can give rise to diseases just like gestational diabetes and preeclampsia in the mother, and which may contribute to preterm labor. So it not only has implications for maternal health, but also may lead to adverse pregnancy outcomes. Maternal periodontal disease may also contribute towards transmission of bacteria, disease-causing bacteria to the newborn babies, and that may result in development of early caries in those babies. So there is strong evidence that oral health care during pregnancy is very valuable, it's beneficial, it's safe and important, and it should be an integral part of all prenatal care. Dental visits during pregnancy not only give an opportunity for oral health screening, early diagnosis and treatment, but that's also a great time for the provider to communicate important preventive messages to the mothers that can impact their health behaviors and can ensure optimal oral health for the mothers and their babies for the lifespan. Next slide, please. So this evidence-based safety and value and importance of oral health care during pregnancy has been emphasized by various practice guidelines, which are issued by professional organizations, both at the state level as well as the national level. For example, the California Dental Association Foundation, as well as the National Maternal and Child Oral Health Resource Center. Next slide, please. So as we know that the Office of Oral Health is continuously striving to improve the oral health of all the Californians through its preventive efforts, through providing education and through community collaborations. California Oral Health Plan, as Dr. Pendurkar mentioned, identifies pregnant people as a high-risk population, which is in need of more focused efforts, and there's a need for a surveillance system to track the progress by looking at monitoring the performance measures. And for this purpose, Office of Oral Health establishes a formal partnership with Maternal and Infant Health Assessment, or MIHA project. And we use MIHA as an ongoing state and local level surveillance system to track progress on oral healthcare utilization during pregnancy. Next slide, please. A little bit of information about MIHA, on Maternal and Infant Health Assessment. It is an annual population-based survey of California residents with a recent live birth. MIHA is implemented by CDPH, Maternal, Child and Adolescent Health Division, in collaboration with the University of California, San Francisco's Center for Health Equity. The information that MIHA captures is unique. It tells us about maternal experiences, attitudes, and behaviors during pregnancy. This information is not available in California from any other source. Many of you may already be aware of CDC's multi-state survey called PRAMS, or Pregnancy Risk Assessment Monitoring System. So MIHA uses the same methodology and questionnaires. PRAMS is not available in California, so that kind of specific unique information is only available through MIHA in California, and therefore it is used extensively by state programs and many other community partners for monitoring oral health, not only oral health, but many of the maternal and infant health outcomes, including, of course, oral health. Next slide, please. And I'm sorry, I forgot to mention about MIHA's funding. It's funded by the federal Title V block grant called the Maternal and Child Health Block Grant, but it's also funded by many internal CDPH sources, including, of course, the Office of Oral Health. My apologies about that. So coming back to this slide, let's review together. These are the findings from the latest MIHA data from the year 22-23. As we can see here that a little less than half of California's pregnant population is actually visiting a dentist during pregnancy. Disparities exist based upon age and the level of educational attainment. Pregnant people belonging to younger age groups are less likely to receive a dental visit, whereas we can see that college graduates have a higher prevalence of dental care utilization during pregnancy. Next slide, please. So this slide depicts some inequities in dental care utilization based upon race and ethnicity. We can see here that the pregnant population of color, specifically Black and Hispanic pregnant people, have the lowest prevalence of receiving a dental visit during pregnancy. And let me please spell out the abbreviations here. They were expanded at the bottom of the slide, which I don't see here, but I will just spell these out. So AINAN means American Indian and Alaska Native populations, whereas NHPI stand for Native Hawaiian and Pacific Islander. Next slide, please. So this slide shows the disparities that exist according to the type of insurance coverage and household income. We can see here that the pregnant population covered by Medi-Cal has lower utilization rates of dental care during pregnancy, whereas the pregnant people belonging to lower income groups also show lower utilization of oral health care during pregnancy. So these findings suggest that there are needs to continue our work towards achieving equitable oral health care, especially for these groups which are considered traditionally underserved, like low-income population, Medi-Cal beneficiaries, and especially the women of color, so that we are able to achieve equitable oral health care access for all. Next slide, please. So let me show you this map here. This is a map of California. It illustrates the variations and the patterns in dental care utilization during pregnancy across MIHA regions.
Okay, let me just turn my volume down on this. I'm just listening to a thing, no worries. Okay. How's it going?
May I request everybody to please check if they are on mute? Thank you so much. So this map illustrates the variation across California for the purpose of survey Implementation and analyses, the Maternal, Child and Adolescent Health Division divides California into 9 MIHA regions. As a quick reference, whenever Office of Oral Health shares the latest MIHA data annually with their local partners, we make sure to share the MIHA regions map as well, including the names of the counties which are included in each specific region, so that it's easier to identify the respective counties. So the darker green areas show greater utilization. So these patterns just tell us how unique each region is, and each region reflects its unique demographic and socioeconomic and healthcare access characteristics. And definitely those all contribute to these varying patterns. Areas of low utilization may be having limited provider availability, or just not enough dental providers available to accept medical insurance, or just the broader socioeconomic challenges that may contribute to these variations in the utilization of dental care during pregnancy. And this just underscores the importance of tailoring the interventions to the specific needs of each region, and for that matter, each county. Thank you so much. And next slide, please. This is a quick overview of the counties that are included in each specific MIHA region. Just to reiterate, this information is shared with our local program partners whenever the MIHA data is sent out by the Office of Oral Health. Next slide, please. And before I could talk about this slide, another quick mention that although the map has shown regional data, the MIHA data that is shared with our local program partners has detailed granular level data available at the county level as well. So please refer to the data files shared if you would like to look specifically at your county. So talking about this particular slide, it shows a trend over years. We see that there's a steady upward trajectory in the percentage of California residents with a dental visit during pregnancy, especially since 2021, we have seen this uptick. This small dip in 2021 may be explained because of the peak of the COVID-19 pandemic during this time. So the California target, which is set by the Health Resources and Service Administration's perinatal infant and oral health quality improvement performance measure. It's actually a performance measure that we have adopted from HRSA, and that's 48%. And we are glad to announce that we have hit the target, but obviously there's still our work has to continue and to achieve even greater success. Next slide, please. So this slide shows trends over time based upon the insurance type. So we see here that although there has been a consistent improvement, the medical beneficiaries still have lower utilization of dental care during pregnancy. Next slide, please. And this slide depicts the disparities based upon race and ethnicity. If you look at the trend over years, again, a consistent, steady improvement based upon race and ethnic groups in every group. But the pregnant people of color, which are shown here, the red line denotes the Black population and the purple one denotes the Hispanic Latina population. They are still receiving a much lower prevalence of dental visits during pregnancy. Next slide, please. So up to now, we have discussed the prevalence of dental visits during pregnancy or dental care utilization during pregnancy. Office of Oral Health also funds this question to be included in MIHA on cycle-on, cycle-off basis, which is regarding barriers to dental care utilization during pregnancy. So the pregnant people who are surveyed are given a list of reasons, and they may choose more than one reason or identify more than one reason. As we can see here, that the more common barriers are actually associated with maternal oral health behaviors and attitude, because 58% of the women saying they didn't need to go, or they were too busy to go, as seen here in this bar that says 40. And almost 1/3 of them surveyed said that they didn't think it was safe to go to a dentist during pregnancy. Lack of dental insurance and cost were also among more common barriers. Lesser prevalent but still important barriers were somebody in the dentist office told me to wait, or couldn't find a dentist who would see me. So this all points towards the need for improving oral health literacy and just sending out and disseminating these important messages that dental care is safe and important during pregnancy, and also maybe to explore the options where there are more dental care providers accepting medical insurance. A lesser common reason was that somebody in the prenatal care team advised to wait until after pregnancy. Again, just underscoring the importance of improved oral health literacy, not only among the public, but also among the providers. Next slide, please. This is an interesting slide. It compares the barriers data from 2012, the first time it was included. This question was included in the MIHA survey, and then comparing it to the latest barrier data from 2022. We can see here that although the barriers related to cost and no dental insurance have actually declined progressively, the barriers which are associated with maternal health behaviors and attitude towards seeking care, like didn't need to go or too busy, have actually increased in prevalence. So again, it emphasizes the importance of crafting targeted public health messages just to promote the safety and importance and value of oral health care during pregnancy. Next slide, please. So I'll just remind all our program partners about these infographics that Office of Oral Health created a while ago, and these are available on Kotek's website. There are two separate infographics with targeted messages towards the healthcare providers as well as for the public. So this one is aimed at the healthcare providers. Next slide, please. And the next one is meant with a specially focused message for pregnant population, just highlighting the value and the benefits of oral health care during pregnancy and urging them to seek dental care during pregnancy. Next slide, please. So I at this before I delve into this slide, I'll just really thank you all our program partners in California for just being our partners and our collaborators to continue our great work, and we'll explore some next steps. A review of the data shows that there is a need for a multidisciplinary approach, which will most importantly will involve medical dental integration, where the prenatal care providers and the dental providers can provide consistent messaging, and they can work together in a synergistic and coordinated and more cross-functional way to promote oral health. And this may involve training, education, maybe some incentives to incorporate and foster these changes into clinical practice. It's really, it would be really helpful if the prenatal care provider team can prioritize a quick exam, communicate important preventive messages during that time, and more importantly, make referrals, appropriate referrals to the dental care team during this time. not only during pregnancy, but also in early postpartum period. I cannot stress enough the importance of targeted oral health education programs and messages. Office of Oral Health has this wonderful resource, the Oral Health Literacy Toolkit. We can expand its use to oral health care providers, which can then utilize this to effectively communicate the messages to their patients and the communities. We can establish and strengthen our partnerships with the local dental and primary care providers associations. We can definitely explore partnerships and really utilizing the wonderful work that the community health workers do in their communities for community education and for increasing outreach to educate communities about expanded medical dental program benefits, which are now since April of 2022 are available for a 12-month period postpartum. If there's any need of financial and social support to overcome barriers like lack of childcare or transportation, that should be explored to overcome the cost and logistics barrier. Another important aspect would be to work towards development of a diverse workforce, more providers who belong to the racial and ethnic minority groups may be helpful in overcoming some of the cultural and language barriers as well. So it's really important that we just continue to work together and address these disparities, the inequities, the barriers that limit the access to oral health care during pregnancy, and just to ensure that every pregnant person in California receives the equitable oral health that they deserve. Thank you so much. Next slide, please. And I think that's all. I'll just take a quick moment to thank everyone for being here today. Thank you very much, Dr. Pendurkar, my entire team, for their support. Thanks to our friends at Kotak for their support, and just very grateful to everyone. Thanks a lot. If there are any questions, I'm happy to answer if I'm able to. Thanks a lot. And I'll give it back to Janelle. Thank you, Janelle.
Thank you so much. That was such an important presentation, all the data that you're sharing. We did have one question in the chat from Ariel. She had asked, do you think the barriers data was affected by COVID? Since the data was released in 2022, is that when it was asked or was it asked earlier?
Oh, thank you so much, Ariel. That's such a good question. So this 2022 data means that this survey was in field in 2022. So you are right. It might have gotten some impact from the COVID-19 pandemic. So the barriers question, as I said, that it's included on a cycle off basis. So Office of Oral Health has included that question in MIHA in the years 2012, 2016, 2019, and then 2022. So thank you so much. Yeah, we don't have any evidence that how much was the impact from COVID, but yeah, most likely it would have been impacted by COVID. Thank you.
Thank you. Ariel, did you want to say anything else or have any other questions related?
No, that was it. Thank you. I just wanted to give that help, try to understand that context. So I appreciate it, Shamila. Thank you.
Thank you, Ariel.
All right, there's another question. Is there a contact person at CDPH if we would like oral health data for our county?
Yeah, so the oral health data we utilize for our various oral health indicators, we utilize different data sources, and different people in our team are actually like focused on different sources of data. So if you would like to please specify, or was it in generally the oral health data or any specific indicators that you're looking for, or any specific source of data or any specific topic, if I may say?
This
I'm
question
sorry.
is from
Yeah,
Andrea.
I'm sorry. I'm sorry for posing a question in response to a question, but this would help me. or you can always like email me, and I can definitely be able to either help myself or direct to the most appropriate resource in our office.
Great, thank you. And there was Cherie had asked a question, will Office of Oral Health and/or Gainwell Smile California be developing messaging around the impacts to coverage due to HR1?
Okay, so for this question, please allow me to defer to our um, uh, team, the local oral health programs and statewide interventions unit, if somebody would like to help with answering that question.
Hi,
Or
Shumaila. I can take that. I think Eileen has also put something in the chat
thank you so much.
regarding that information. So it seems like the Medical Dental Services Division has developed a template for the notices around the FAQs. And so that information hasn't been released yet, but it's forthcoming. So I hope that answers the question.
Oh, great.
Thank you so much, Dr. Pendurkar.
Let's see here. Hyam had said, great presentation and information. In Alameda County, we began implementing the state-funded perinatal demonstration project to develop and describe a successful model for improving access to dental care. This presentation will be so helpful as we describe our demonstrated and successful model that was piloted in Alameda County. And Chelsea had asked, is there a reason why certain counties don't have data for specific ethnicities?
Yeah, thank you so much. That's such a great question. So actually, MIHA collects data for the top 37 birthing counties. So, and sometimes if the sample size is too small, just because of in order to comply with the data confidentiality guidelines, especially the CDPH guidelines, as well as the other general guidelines, the data is not available. So sorry about that. If it all depends upon the sample size, if it's too small, then unfortunately, it's not available.
Thank you.
Thank you.
Another question asked, were the barriers assessed in 2022 shared with LOHP along with the MIHA 2022-2023 datasheet?
Yeah, it was. As I recall, yeah, it was.
Great.
Thank you.
And is the fluoride infographic available as a template? Did the map use My Water's fluoride data? Oh, Margaret answered. That's to come. Alrighty, great. Were there any other questions?
Sherry, would you like to explain your comment in the chat, please? About the 12 months postpartum? Not sure what you're asking.
Yeah, I just wanted to give some context. It seemed kind of random for my question to be dropped into the middle of the presentation regarding if there would be more information coming out on the impacts of coverage due to HR1 and like when to anticipate that. What triggered me to think of it was when Shamila was sharing about the 12 months postpartum. I thought, oh, is that going to be one of the things that it's going to be impacted? And then I thought, where can I find that information? So my question seemed a little out of context. So I just wanted to drop into the chat. Sorry about that.
No,
But that's
no
what
worries.
triggered me
Just want
to
to make
think about
sure.
it.
Oh, no, we just want to
Yeah.
make sure we are addressing your questions. But what we know so far is that July 1st of 2026 is when dental coverage for the unsatisfactory immigration status folks 19 and above will discontinue. That is what we've heard so far from Medi-Cal Dental. And so as more information becomes available, they will be sharing that, as Eileen mentioned, and we can also share it when we become aware of it. So that's what we know so far. I don't know if it helps you or not, but
Yeah,
that's
thank you.
the extent of the information so far.
Yeah, the resources shared, Ariel shared, and then I will keep my eye out for the one Eileen mentioned. So
Sure.
thank you. That was
Yeah,
great.
you're welcome. You're welcome. And I thought there was a question around if someone wants information on data for their county, who should they reach out to? And I would say, please reach out to our surveillance and evaluation unit. You've got Shumala here and Margaret as well. You can always email us at dentaldirector@cdph.ca.gov, and we will certainly try to get back to you depending on what your request is. I can't remember who the question was from, but I thought I saw something in the chat here earlier.
Yes, thank you. Thanks for answering that.
Thanks.
Alrighty, we have a couple more minutes for any other questions. Alrighty. Well, thank you again, Shamila.
Thank you so much, Janelle.
Now we'll
Thank you.
turn to Margaret Trimble, who will present new data and communication tools related to community water fluoridation.
Okay, thank you. Thank you, everyone. Dr. Pendurkar, Shumila, Janelle, everyone at Kotak, thank you. And thank you, everyone, for being here. My name is Margaret Trimble, and I am an oral health epidemiologist with the Office of Oral Health. And I am super excited to share with you an infographic that was developed by the Office of Oral Health that presents the health and economic benefits of community water fluoridation. Next slide, please. So the learning objectives for today's presentation are to list the key benefits of community water fluoridation, to state the purpose of the community water fluoridation infographic, and to explain the data points of the community water fluoridation infographic. Next slide, please. Okay, I want to give a little background about community water fluoridation. It is, first of all, one of the top 10 public health achievements of the 20th century. It is right up there with seatbelts and vaccinations. So it is a very important and successful public health measure. Nevertheless, it has faced community water fluoridation has faced renewed scrutiny due to federal actions and a recent court ruling. The California Department of Public Health, however, issued a joint statement back in April of this year to support community water fluoridation as being a safe and effective way to support human health and to prevent tooth decay in children and adults. Next slide, please. Okay, and to provide a little more context about community water fluoridation in California specifically, there are over 3,000 public water systems in our state, and some public water systems add fluoride and many do not. The recommended amount of fluoride in drinking water is 0.7 milligrams per liter, which equals 0.7 parts per million. So those are interchangeable. And one way to visualize this is it would be the same as 3 drops of fluoride in a 55-gallon barrel of water. So that's the amount of fluoride we're talking about. To prevent cavities. And currently, roughly 50% of Californians are served by public water systems that fluoridate. Communities that have recently considered stopping fluoridation of their public water systems in California are Oroville, which is a city in Butte County, and Olivenhain, which is a public water system located in San Diego County. Next slide, please. Okay, first I would like to review the key benefits of community water fluoridation. This may be very familiar to you all, but I think it is worth reviewing. First and foremost, community water fluoridation offers protection against cavities for people of all ages. It reduces cavities by about 25% in children and adults. And we know this because of research that was conducted in communities where fluoridation was stopped. And in each of these areas, when fluoridation was stopped, the prevalence of tooth decay increased by around 25%. So this happened in Juneau, Alaska, in Calgary, Alberta, Canada, and Windsor, Ontario, Canada. Secondly, community water fluoridation promotes health equity. It benefits all community members, regardless of their access to dental care. Not everyone has access to dental care, and not everyone even has access to fluoridated toothpaste, but everyone has access to tap water. And whether it be drinking it directly or using it for cooking, even if you boil tap water, you are not going to remove the fluoride. Thirdly, community water fluoridation is cost effective. For every $1 invested, approximately $38 is saved in dental treatment costs. Furthermore, community water fluoridation contributes to reduced pain and absenteeism. And this goes back to the fewer cavities. So fewer cavities means less mouth pain and subsequently fewer missed days of work and school. And finally, community water fluoridation is safe and effective. It is supported by substantial scientific evidence. And aside from being endorsed by CDPH, California Department of Public Health, it is endorsed by other major organizations like the CDC, the American Dental Association, the World Health Organization, as well as medical organizations like the American Medical Association and the American Academy of Pediatrics. So we got some heavy hitters that support this. Oh, next slide, please. Okay, the purpose of this infographic is to visualize the economic and health benefits of community water fluoridation at a local level. It is also meant to provide local oral health programs and other partners with local statistics on community water fluoridation. It is meant to support local oral health programs and their partners in their efforts to promote oral health and reduce oral health disparities. And ultimately, it is designed to educate and encourage local policymakers in their efforts to maintain our community water fluoridation system. Now, it's very important. I want to make sure that it's clear that this infographic describes the health and economic benefits of community water fluoridation for communities that are currently fluoridating their public water systems. And there is maybe some discussion about stopping that fluoridation. It is for those communities that this infographic may have the most impact. Next slide, please. Okay, here is the infographic, and I'm very grateful for Dr. Pendurkar for actually introducing it earlier on. I think it's important to just repeat a lot I think repetition is helpful when being introduced to new things here. So Office of Oral Health can customize this infographic for you. And I want to go through each of the parts of the infographic and all of the data points so that it's clear and so that you can utilize it effectively. So let's go ahead and start with the first element, and that will be on the next slide. Okay, so the map. So what does this map show? This map, as the title says, this shows the percentage of the population served by community water fluoridation. So counties in the lightest shade of purple have the lowest percentage of the population that is currently served by community water fluoridation. And you can see in the legend that it ranges from 0 to 7%. And indeed, there are counties out there where 0% of the population is currently being served. On the other hand, counties in the darkest shade of purple have the highest percentage of the population that is being served by community water fluoridation. And there is one county where 100% of the population is currently being served by community water fluoridation, and that county is San Francisco. And I think this is so. I think Christy had a question in the chat earlier. This map, the data for this map comes from the CDC My Waters Fluoride Fluoridation Status Report. So just to answer that question. Next slide, please. Oh, okay. And I'll answer other questions after. Okay, so let's take a look at the top 3 boxes of this infographic, and we'll go through them one by one. So first, the population served by community water fluoridation. For this particular county, 5.8% of the population was served by fluoridated water, and that comes from CDC My Waters Fluoride website as well. And I took that 5.8% and multiplied it by the county population estimate. And that's where we come up with the 12,057 people who are currently served by fluoridated water. Next box here, the middle box, communities with fluoridated water save an average of $44 per person each year in dental treatment costs. And where does that $44 come from? There was a study in 2016 that used 2013 data, and that study found that communities with fluoridated water save an average of $32 per person per year. And to account for inflation after all those years, we got the consent from one of the authors of that study to go ahead and plug that into an inflation calculator, and that's how we came up with the $44 per person each year. So if we take that $44, multiply it by the number of people being served, that 12,057, that gets us the collective annual savings of $531,000. So bottom box here. So if every person, if all of the money that was saved, it goes to purchase products and goods that are subject to sales tax, that's going to generate a lot of sales tax. Now, when you purchase something that is subject to sales tax, most of it goes to the state, but a fraction of it comes back to the county where it was purchased. And in this case, it happens that this county, that amount is 2.25%. And so if we multiply 2.25% by that collective savings, $531,000, we get the amount for local use, which is 11,936. And so it's just important to keep in mind that the more, going back up to that first box, the more the population, the greater the population that is being served, the greater the collective annual savings and the greater the potential sales tax revenue for local use. Next slide, please. Okay, so this is the bottom box of the infographic. And this box just contains other relevant points that are designed to further support maintaining our community water fluoridation system. And I'd like to go through each of these points one by one. So first, this county happens to have a poverty rate that is substantially higher than the statewide poverty rate. And the reason why that is important is that people in poverty may also rely on Medi-Cal for dental care. And as you may know, it can be challenging to find a dental provider who accepts Medi-Cal, which makes protective infrastructure such as community water fluoridation even more important. Similarly, this county doesn't have very many dental providers who take Medi-Cal, and even fewer that are accepting new patients. So again, just to make that argument for community water fluoridation. Now, the last three bullet points are not specific to any particular county, but they are general points that really deserve to be emphasized, and we'll go over those. So again, to repeat, on average, communities with water fluoridation experience 25% fewer cavities than communities without water fluoridation. This means less pain, fewer fillings and teeth pulled, and fewer missed days of school and work. And I've included a link to my colleague Shumaila's beautiful infographic that provides details on the number of missed school days due to dental problems in California. Next bullet point, research shows that delayed dental care is associated with increased emergency department utilization, where the cost of care can be triple that of preventive dental care. So a very inefficient use of resources. So again, making the argument for community water fluoridation to reduce cavities, reduce the need for dental care in the first place. And finally, estimates based on new research from Harvard show that if California stopped all water fluoridation, it would cost our state almost $5 billion over the course of 5 years. So next slide. So to summarize, maintaining the current percentage of Californians who are served by community water fluoridation is important. The Office of Oral Health can customize this infographic for your local health jurisdiction. We want you to know that we are here to support you as you navigate the challenges that you might face regarding this topic. Please reach out to your program consultant if this research would be useful in supporting your local community water fluoridation efforts. And next slide. Thank you very much. And I am very happy to answer any questions that you may have. And I think there might be some in the chat.
Thank you, Margaret. Yes, there's a few. Claire had asked, does the map show percentages served with optimal fluoridation? So the 0.7 parts per million. My water's fluoride has a yes/no column under fluoridated for water systems. And when I clicked on our county's individual water systems and read more about each, it didn't seem that all of them marked as yes on MWF were also necessarily optimally fluoridated at that 0.7 parts per million rate.
That is a great question, Claire. Yes, and I'm kind of delving in, I'm exploring this more myself. So according to the glossary, there is a glossary on that website, on the My Waters Fluoride website, and the fluoridation status of yes is intended to mean those that are optimally fluoridated. It is supposed to be delivering optimally fluoridated at that 0.7 parts per million. And yes, there may be some average amounts, monthly average amounts that go below that, but on average, that is what it's supposed to be according to the glossary on that website. So I can't say, I'm not sure of anything else beyond that, but it's certainly something that I know we're trying to get a very accurate database going for California.
Great, thank you.
Yeah.
Ariel had asked, are there concerns that CDC may alter, remove, or cease gathering this data? Is the Office of Rural Health saving this data for California and the counties? Is it recommended local counties save our own data?
Yeah, that is another great question. And I know that we're working on addressing those concerns right now. And we definitely want to be getting something that's accurate and create some sort of system where we are tracking. And woo, our expert here, our fluoride expert, may have some more to share about that. Thank you so much, Cindy. Go ahead.
Thank you, Margaret. That was an amazing presentation. Yes, the My Water's fluoride is populated by the State Water Resources Control Board, and they are the regulatory authority over fluoridation and water. And it has been advised to archive all of the previous data because, as we know, the Office of Oral Health has been eliminated at this point, and the contract for wafers expires in the middle of January. So if you do have data, we're going to recommend work with the State Water Resource Control Board to archive that data. Good question.
Office of Oral Health at CDC. Yeah, thank you, Cindy.
Thank you so much, Cindy, for clarifying that.
There was an extra question after, for customization, can this be done at a jurisdiction or city level?
Oh, great question. Yeah. That will be done. It may be possible, and we'd have to look at that kind of at a case by case. Um, so if there's something, that you want us to look at specifically, please reach out to your program consultant and we can take a look at that.
Thank you. So those are the questions in the chat. Are there any other questions? No others? We still have some time for questions. This is our questions for any of our speakers. But yeah, I guess if not, we can close a little bit early. We do have a few announcements. Our
Janelle,
next,
can I ask a quick question?
yeah, sure.
Thanks. Thank you so much, Margaret, for this presentation and for the team for all the work that I'm sure went into preparing this. As you indicated, this is most helpful for those communities that may be considering removing fluoridated water or may have other groups that are interested in having the water fluoridation removed. One of our advisory committee members has been very interested in having community water fluoridation being added in a community that doesn't have it. And return on investment is something that has been a really big topic among that particular individual and the group that they work with. I'm curious if there's any interest or plans or if different calculations can be shared with LOHPs so that we can work on some sort of infographic or some sort of information on return on investment for communities that may not currently be fluoridated, but maybe considering it, or maybe have groups who want to advocate for that to happen.
Ariel, thank you for that question. I would highly encourage you to get in touch with Margaret, and we can certainly work on the infographic for Sonoma, but then also specifically to your question, Margaret can provide details in terms of how you might want to look at it for specific areas within your county. So please reach out to Margaret.
Yes, absolutely. I'm happy to help, Ariel. That's a great question. And I feel like, yeah, I feel like there could be some minor tweaks made to help present some information that would facilitate addition of fluoride to your community. So that's great.
Thank you. I'll follow up. I appreciate it.
Thank you. Yeah, so just a couple more announcements. Our next COTAC office hours is December 16th, focused on National Children's Dental Health Month. Our next Share and Learn will be February 19th, where we will be discussing partnering with Head Start. Save the date will be shared real soon. And we migrated to our newer version of our website last week. So we're still finding a little bugs here and there. Please, thank you for those who have sent us the emails to let us know. Please continue to do so and we'll fix those. But Xenia will now launch our evaluation poll and share the Qualtrics links in the chat. We greatly appreciate you taking the moment to complete the survey, as it will help guide future sessions.
Oh, yes. Since we have some time left, there are 2 new questions in the chat.
Oh, great. Let's see here. Claire's, is that the one?
And Eileen.
All right, I see Claire's. For MIHA data and the answer option do not need to go. Is there any more info about what that answer could mean or imply? I'm not sure how to interpret it, like people feel their mouth health is fine, or maybe they went to the dentist right before pregnancy and don't feel the need to go in the next 6 months. I'm not sure why they opted for that answer and how to interpret it.
So, thank you, Claire, for the question. I'll try to answer that. So, so this question funded by Office of Oral Health was included in the MIHA survey, obviously before I joined it, but the Office of Oral Health. But the general understanding, I'll try to answer from that general understanding of how survey questions are formulated. They are always done in consultation with the subject matter experts. So just for example, the funding organization or the office or the branch that is interested in tracking a certain oral health indicator, they would express that need to the subject matter experts. They may be at MCH or maybe at the University of San Francisco Center for Health Equity. And then they, according to their own expertise and their knowledge and training, would make recommendations. So this is from my general knowledge and general understanding of how this process works. I'm sorry, I don't know specifically about how MIHA works, but if you're interested and if you would like to, please directly contact MCH or the MIHA project. I can put the links in the chat.
Okay. Yeah,
So-
thanks, Shamila. I just only because it was the top reason recently, so it's like,
Yeah.
so is that like do we take that as it's sort of like misinformation or disinformation that now we're supposed to address as LOHPs, like really push the message that it's necessary and important to go, or if it's, like I just not, so do we need to really focus on that? I know we always do, but since it was that was the highest reason, it makes me really wonder what's really behind that. So yeah, thanks for the methodology that and maybe we can dive deeper into it.
Claire,
No,
thank you
so
for that
much.
question. And you're absolutely right. As Shumaila mentioned, this is an opportunity for us to educate and inform, because if that is something that folks are thinking that they don't need to go, then that is a gap in what folks think is important during their pregnancy as far as the oral health goes. And so it's definitely an opportunity to inform and educate. And that's where the focus could be directed. As far as reaching out to MCH and trying to dig a little bit deeper, certainly, feel free to reach out to Shumela afterwards, and also the information that Shumela will share with you. You can definitely dig a little bit deeper into that. But I think the take-home message would be that this is where we see a gap, that even now folks think that it is not important or they don't need to go. And so we certainly need to take the time to educate and explain why it is important to have good oral health during pregnancy.
Yeah, thank you so much, Dr. Pendurkar. Yeah, definitely, this is of prime importance, like to get that message across. Thank you very much. And thank you.
Oh, go ahead.
I just wanted to thank Claire for for the thoughtful question. Thank you.
I want to acknowledge some of the comments in the chat box. El Dorado and Alpine do not have fluoride in the water. Yes, that is challenging. And I think there was another comment earlier where there's about 200 sources of water in the county, and so it would be difficult, mono and inyo. And so we certainly understand the challenges with that. And as far as informing, again, as public health professionals, our job is to inform and educate, and that's what we can do. We can certainly help with the infographic, as Margaret said. We can prepare the template, the infographic for your counties, and that might be something that you could use in terms of educating and informing the policymakers in your own county. But I want to acknowledge the challenges that you guys face because of, whether it is multiple sources of water or whether it's just that there's no interest in fluoridating the community water systems in your county. So thank you for those comments.
Yes, thank you. And we had another question from Eileen. I'm curious if and how Carrie's experience data across age ranges tracks with regions of the state without CWFs.
Yeah, at this time we have data on KDS experiences in some counties based on the third grade survey. And we have the community water fluoridation map. There is no analysis that has been done to show if you're asking if there's a correlation or a causal effect. Unfortunately, that type of analysis is much more complicated with the limited data sources that we have. But yes, Eileen, thank you for bringing that up. That is something that we have definitely looked into and considered doing and trying to figure out how we can try to get that information. This has been ongoing for the last year or so since I came on board, just to try to see if there's a way that we can potentially look into that type of causality, if you will. Unfortunately, we don't have the resources to dig into that at the moment. Thanks for that question.
Thank you, Eileen. And there was one question for Margaret about how to get in touch with you for creating infographics. Should we attach your email to our...
Please reach out to the PCs. We would like to
Okay.
keep our PCs involved. So every county has a program consultant. Please do reach out to your program consultant, and then we can work on that.
Great, thank you.
So if you have a moment, Janelle, I'd like to again say thank you to everyone first for being here and really for the tremendous work that you're all doing. We don't get too many opportunities to meet with you all and to say thank you and to show appreciation. But please know that you are first and foremost in our minds as we are doing our work here at the state. I've been at the local level, so I totally get it. I totally understand where you're coming from and what you're doing and the challenges that you face. And we're just so grateful for your partnership. So thank you for all the hard work. And, understand that we are here for you. So if you need anything, please do reach out and we'll do our best to figure out how we can support you. So thanks again and have a great holiday season if we don't see you before the end of the year. Take care.
Thank you, Dr. Pendurkar. And I'm going to launch the Zoom poll. If everyone could take a moment to take the poll, and I will be pasting our Qualtrics poll in the chat as well. There are two different polls. The Zoom one is for multiple choice, and the Qualtrics is for your open-ended feedback. Thank you. Thank you to all the speakers.